We're going to move on to our next presentation. Our next talk is a tandem presentation by Dr. Srivastava and Dr. Anne O'Donnell, who will be familiar faces to our US-based families. The title of this talk is Neurodevelopmental Concerns and Latest Molecular Updates. So I'll introduce you to Dr. Sid to start.
Can you see and hear me okay?
Okay. Yeah, yes, thank you.
Excellent. So thank you so much for that introduction. So today I'm going to talk about a general introduction to neurodevelopmental challenges and Kleefstra syndrome. I'm going to focus my talk on certain key areas of concern for affected families. I don't have enough time to touch base on every aspect, but I'm happy to answer questions at the end and talk offline in more detail. So first, some quick background. As all of you know, Kleefstra syndrome is a genetic disorder associated with several systemic features, as well as a full spectrum of neurodevelopmental challenges. And these challenges include intellectual disability, autism spectrum disorder, attention deficit hyperactivity disorder, anxiety, hypotonia, and many, many others. So why is it important to address challenging behaviors and developmental concerns? Well, the answer is pretty easy. These can affect the quality of life for affected individuals and their family members. And addressing these concerns early on, whether that's through medications, therapies, or other types of interventions, can absolutely improve long-term outcomes. So let's get started. So let's start by talking about intellectual disability in the context of Kleefstra syndrome. So at a very basic level, intellectual disability relates to impairments in cognition. And when I mention cognition, what exactly do I mean? So cognition refers to our innate problem-solving abilities, and IQ testing is one way of assessing for cognition. For example, here are standard scores from a sample IQ report. Focus on the full-scale IQ number. Here is how I interpret this. Take the full-scale IQ, multiply it by your child's actual age, and divide by 100. So this is your child's developmental age, meaning that's how old he or she may act or think like. Once again, this is a rough approximation. So for example, if you have a 5-year-old child, and they have a full-scale IQ of 65. So their cognitive age is about 5 times 65%, or about 3.25 years old. Intellectual disability then is defined as having a full-scale IQ less than 70 with significant limitations in adaptive or self-help skills. IQ is not necessarily static. For the most part, it's stable, but it can change a little bit over time. A wide range of intellectual disability can occur within Kleefstra syndrome. So mild ID is defined as having an IQ between 50 to 70. Moderate ID is defined as having an IQ between 35 to 50. Severe ID is defined as having an IQ between 20 to 35. And profound intellectual disability is defined as having an IQ less than 20. However, in some individuals with Kleefstra syndrome, they can have normal IQs. So there's no ID-specific treatment for Kleefstra syndrome. Well, I think not yet, at least, and I think that's one of the long-term goals, is to develop more specific targeted treatments for ID within the context of Kleefstra syndrome. I think one thing I want to emphasize is that in school, it's really important to make sure that academic demands and expectations are aligned with respect to a child's intrinsic cognitive capabilities. Because if there is an imbalance between intrinsic capabilities and expectations, then there can be a whole assortment of behavioral problems and frustrations. So let's switch gears a little bit and talk about language. So language disorders reflect our ability to communicate. And these are a common challenge for individuals with Kleefstra syndrome. Language is quite important because it's the primary way we interface with the rest of the world. I like to think of language as having two components, an expressive component and a receptive component. Expressive language is our ability to communicate thoughts and ideas. Receptive language is our ability to understand thoughts and ideas. And on one level, receptive language is somewhat like thought and cognition. It's really important to view language in the context of cognition. So for example, let's say you have a 6-year-old, so look on the graph on the left. So let's say you have a 6-year-old child with an IQ of 50. If you multiply 50% by 6 years, you get 3 years of age. So that child should have cognitive abilities at the 3-year-old level and language abilities at the 3-year-old level. So in contrast, so now looking at the graph on the right, if language is disproportionately affected compared to cognitive abilities, then you're dealing with the superimposed language disorder. So for example, 6-year-old child, IQ of 50, but if they have a superimposed language disorder, then their language abilities are much less than the 3-year-old level, whereas their cognitive abilities are at the 3-year-old level. And once again, this is a simplification, but I think it's an important concept to understand. I like to think of 3 pillars in terms of treatment of language disorders: one-on-one speech and language therapy, play/social groups where children learn to model language and socialization from each other, and augmentative and alternative communication. Augmentative and alternative communication, or AAC, so this refers to the use of special devices that allow kids and adults to communicate even in the absence of spoken language. So these devices can be high-tech, such as a mountable electronic device, or low-tech, such as a handmade picture board. AAC is especially useful for children who are nonverbal. It's a great intervention, and I recommend that some families look into it because it may unlock some potential communication abilities, which I think is really important. And one theme that comes up with talking to families in Kleefstra Syndrome and other neurodevelopmental disorders is that there can be mounting frustration when there's decreased ability to verbally communicate, and this can lead to problematic behaviors. And I think this is all the more reason why communication is really, really important to focus on and prioritize. So speaking of behaviors, so let's talk a little bit about attention deficit hyperactivity disorder, or ADHD, which is a common feature of neurodevelopmental disorders, and Kleefstra syndrome is no exception. ADHD is a disorder associated with inattention, distractibility, hyperactivity, and impulsivity. Symptoms have to occur in 2 or more settings, for example, home and school, and they have to be functionally impairing. They have to affect academics or learning or safety or other areas. There are 2 approaches to treatment, and often both approaches may be necessary. A non-medication approach involves behavioral therapy, and the purpose of this is to provide parents and caregivers strategies to redirect your child's behavior. If behavioral therapy is not effective, then medications may be necessary. There are 3 different classes of ADHD medications, which are stimulants, so methylphenidate products, which are stimulants, dextroamphetamine products, which are stimulants, and then non-stimulants. I've used all 3 classes of medications for individuals with Kleefstra syndrome, and unfortunately, I don't think we have enough data yet to support use of one family over another family of medications. Treatment can often require a trial and error approach, starting with one class of medication and switching to another class because of perhaps poor response or side effects. And the goal is to find the lowest dose of medication that's effective without side effects. I often recommend a start low and go slow approach, especially because the metabolism of children with Kleefstra syndrome may be different from that of typically developing children. The main side effects of ADHD medications are decreased appetite and disrupted sleep, but both of these have solutions, and you don't necessarily have to give up on a medication because of side effects. And I also talk about waiting at least 1 week before deciding whether a new medication or dose change is effective or not, and really avoiding the temptation to stop a medication unless there are serious side effects. Choosing which medication depends on your preference for duration of medication and how your child can take medications. Within each class of medications, there are short-acting forms, which last 3 to 6 hours or so. There are long-acting forms, which last 7 to 12 hours. There are pill options, which you can't crush or chew. There are capsule options, which you can open up and sprinkle onto food. There are chewable pills. There are liquid solutions. There are patches, which you apply onto the skin. So there's a lot of different options. And I won't go into the specifics, but just to provide a broad overview of some of the different options there are. Anxiety and depression could be another set of challenges faced by a child or adult with Kleefstra syndrome. Anxiety and depression can have a variety of manifestations. Symptoms can include irritability, excessive worry, perseveration, social avoidance. And sometimes it can be really difficult to recognize anxiety and depression, especially if you're dealing with increasing levels of intellectual disability that is seen within Kleefstra syndrome. As with ADHD, there are two approaches to treatment. A non-pharmacological or non-medication approach involves seeing if there are triggers for the anxiety or depression. There's a specific type of behavioral therapy called cognitive behavioral therapy, which is useful for anxiety. I talk about this type of therapy if there isn't, depending on the child's level of intellectual stability, that may limit this type of therapy. Often medications may be necessary, and I've listed 3 broad categories of medications useful for anxiety and depression: SSRIs, other antidepressants, and sometimes benzodiazepines. SSRIs or selective serotonin reuptake inhibitors are often first-line treatment for anxiety and depression. A low dose of an SSRI can help anxiety and depression in mood states. There's a couple of caveats here. One is that SSRIs can sometimes lead to worsening agitation in some individuals. And second caveat is that I would generally discourage the use of a benzodiazepine for the management of anxiety, for long-term management of anxiety, just because there's a risk of dependency and sometimes paradoxical agitation. And the third caveat, which just to mention, is that sometimes individuals with Kleefstra syndrome can have different changes in how they process medication. So the CYP enzyme system that can interfere with the metabolism of different medications. And in some cases, we'll refer families to pharmacogenomics, where they can test for certain types of polymorphisms or changes in enzyme systems that can provide guidance on what medications to use for anxiety and what medications to not use, for example, to not use in Kleefstra syndrome. So in some individuals, they may have a change in this enzymatic system that may suggest that fluvoxamine, for example, is not such a great choice, or the dose may need to be adjusted. So regression, which is going to be talked about a little bit later by Joost, is a very challenging consideration for some individuals with Kleefstra syndrome. This can be something that happens after puberty, characterized by really significant sleep challenges, loss of self-help skills, behavioral changes such as aggression, psychosis, apathy, other mood disturbances. Early recognition is really, really important. And the reason that early recognition is quite important is that there's some data that supports the use of certain types of medications, such as called neuroleptics or second-generation neuroleptics. Specific examples include aripiprazole and olanzapine. And there's been some anecdotal data and other published data suggesting that this can help halt some of the regressive features or even return an individual back to their baseline. Of course, this really needs to be studied in further detail, but it's promising that we have some insight into potential treatments for this really challenging problem. A major caveat to mention with respect to neuroleptic medications. So these are powerful medications. So there's a potential for serious side effects such as metabolic syndrome, increased levels of cholesterol, increased levels of blood sugar levels, weight gain. So these need to be monitored quite closely. Let me wrap things up. So there's a wide spectrum of neurodevelopmental challenges associated with Kleefstra syndrome, intellectual disability, autism, language disorders, ADHD, anxiety, regression. This is just a couple of features, and I just provided an introduction to some of these challenges, but of course, there's a lot more to it. This is just the tip of the iceberg. Identifying the target behavioral symptoms can really help in terms of medication management. Are we talking about more hyperactive, impulsive behaviors? Are we talking about anxious, depressive type behaviors or mood states? Are we talking about aggressive, self-injurious behaviors? And finally, there's a really great need to study what medications work and don't work for individuals with Kleefstra syndrome. So while I think it's absolutely wonderful, we're all united towards the goal of developing targeted treatments. I think just finding out the medications that are currently used and studying those within Kleefstra syndrome, I think that can also be helpful in the meantime until we have more targeted treatments. So with that said, I'm going to hand it over to my colleague, Dr. O'Donnell Loria, and I can just move the slides along if that's okay with you.
That would be great. Thank you so much. So you can go to the next slide. So a lot of this has already been covered by Dr. Kleefstra, so I'm going to just go through briefly, but we've talked about how in Kleefstra syndrome, the gene HMT1 is really important for packaging DNA. And why do we need to package DNA? Well, in every cell in our body, we have 2 meters of DNA that we fit into these tiny packages of chromosomes that go into the nucleus in each cell. So that's a lot of restructuring that has to happen in the right way. Go to the next slide. And so EHMT1, also KMT2C, which has been mentioned, are some of the proteins and genes that modify the chromatin structure. And chromatin is a fancy word for the organization of DNA as it's wrapped and packaged into cells. And so it helps determine the open and closed regions that are easier or harder to express. You can go to the next slide. And we've already talked about the different genetic causes of Kleefstra. I think of the deletions as I think of our genetic material as being books, being stored in these books with lots of letters, very similar to how DNA is, lots of letters. And with a deletion, you might be missing a few chapters of a book, whereas with a mutation in EHMT1, there's a spelling change in one of the sentences. And so there's different tests for which one you're looking for. And you can go to the next slide. And it's already been mentioned the EpiSign DNA methylation array. So this is a test for people who have a variant of uncertain significance in the EHMT1 gene, or who have a clinical presentation that is very consistent with Kleefstra syndrome, but their genetic testing is negative. This could be a test to identify what's been missed by other testing. It doesn't really help at all at this point in terms of determining like medical issues or prognosis or anything. So it's really just a diagnostic test to help identify individuals who haven't been able to get a diagnosis otherwise. But it does show us that if there's a methylation signature that we can see for Kleefstra syndrome, then there's a systematic pattern of how this chromatin or this DNA is mispackaged in this condition. And so we think that that's going to be interesting for us to be able to learn more about potentially some of the genes or genetic architecture that is different in Kleefstra syndrome, so that we could maybe better understand it and understand some ways to think about targeting some of these symptoms for the future. So next slide. So I just wanted to briefly mention a research study that we'll be organizing through Boston Children's Hospital. It was up and running. It's on hold due to COVID because it involves getting a fresh blood sample and doing some processing on it right away. But the idea of this study, which is a collaboration with Dr. Andrew Strigakis at the University of Washington, is that we are going to look at the chromatin architecture using a new method that he developed that involves long read sequencing. And we can really see exactly how the chromatin is packaged and what the methylation patterns look like on a single DNA strand level, which we think will be hopefully helpful to the community longer term. I think that's all I wanted to say, and I will turn it back to Dr. Srivastava.
The last thing I just wanted to mention is that, so thank you so much, Anne. Wanted to mention that we are starting a Kleefstra syndrome clinic at Boston Children's Goals being to optimize long-term outcomes and coordinate care across multiple disciplines, helping address neurological issues, developmental issues, educational issues, genetics issues, and so forth. And partnering with different specialists in psychiatry and sleep medicine and ophthalmology, ENT, and so forth, and with opportunities to participate in research. Several of you have already started to be a part of this, and we're so grateful and so thankful. Just to mention, right now in COVID times, in some cases we can do telemedicine visit for new patients, although we're facing various challenges with respect to insurance and out-of-state medical licensure. So just some patience as we kind of sort through that and work through that. But if you're interested and want to learn more, there's contact information for some of the admins who work with our clinic, and feel free to get in touch, and we'll do our best. Once again, certain limitations and challenges, but we'll try our best. Thank you.
Thank you so much, Sid and Anne, for your talks. We've got some themes emerging in our Q&As, particularly about genotype-phenotype correlation and whether we can correlate certain types of mutations or certain phenotypes with each other. So I'm going to ask Anne and Jitska to start commenting on those on the chat, and we can talk about them more on the panel. But I feel we should move on to our next speaker.